Okay, so now we will continue with a presentation on the lung cancer by Dr. Shino. بس بالماوس سكرول ويل okay.
Good morning. My subject today is about the lung cancer. The lung cancer is the leading cause of the cancer death in the USA. 5-year survival is 15%. We have many risk factors for that. First of all, it's the tobacco smoking. Almost all the squamous cell carcinoma and the small cell carcinoma are associated with smoking, and to a lesser extent the adenocarcinoma. Also, we have occupational environmental exposure like beryllium and radon, pulmonary fibrosis, and pulmonary scarring like TB. We have solitary pulmonary nodule. The nodules are most common finding, so we have many types of this, either benign, intermediate, or malignant. But we have some features that benign nodules have some features like central laminar and diffuse calcification, or popcorn calcification, or intra-lesional fat. Here, there's a nodule with calcification, and here also this chest X-ray. Also, there is the soft tissue nodule with popcorn calcification, and these two cases are hamartoma. Nodule that's suggesting but not diagnostic of benign, small nodule, usually benign. A nodule less than 3 millimeters has 0.2% risk of malignancy. Calcification in the small nodule, non-round shape, including oblong, polygonal, triangular, or geometric. Subpleural location and clustering of nodule, which are most commonly in the occur in the infectious process. Nodule suggesting malignancy, the size. The large size is the single most important risk factor for malignancy, regardless of morphology. We have the nodule, which are suspected malignant nodule, irregular edge or speculated margin, round shape, cavitary nodule, or nodule containing small cystic spaces. Here, the cavitary nodule with multiple small cystic nodule and surrounded by, which is the irregular margins, and surrounded by the ground glass opacity. Nodule less than 4 mm with the patients with no risk factor, no need follow-up. We have Fisher Society follow-up recommendation for non-calcified nodule without history of malignancy. We have low risk and high risk patient. Nodule less than 4 mm in low risk patient, no need follow-up. In high risk, 1 follow-up at 12 months. If unchanged, no need follow-up. Nodule 4 to 6 mm even in low risk, need 12-month follow-up at 12 months. In high risk, 2 follow-up at 6 and 12 months. If no change, at 11 to 24 months. 18 to 24 months. Nodules 6 to 8 mm need in low risk patient 2 follow-up at 6 to 12 months, or if there's no change, at 18 to 24 months. In high risk, need 3 follow-up at 3 to 6 months, 9 to 12 months. If there is no change, at 24 months. Nodule more than 8 mm, regardless of the risk factor, PET scan, biopsy, or 3 follow-up at 3, 9, and 24 months. We have histological subtypes of lung cancer. We have either small cell or non-small cell cancer. Non-small cell include adenocarcinoma, sequamous, and etc. Adenocarcinoma is the most common subtypes of the lung cancer. It's present as the peripheral pulmonary nodule, speculated outline due to reactive fibrosis. Cavitation may occur, but it's less common than that of the squamous cell carcinoma. We have useful pathological marker TTF1, that's thyroid transcription factor, which is positive in this and negative in metastatic from the adenocarcinoma. Second type, we have squamous cell carcinoma, which is the majority of them arise centrally from the main lobar or segmental bronchi, cause early symptom because it's central, and due to bronchial obstruction may cause hilar mass or lobular. Radiological features appears as a lobar atelectasis, mucoid impaction, consolidation, and bronchiectatic. It's also cavitate. These are the cavitary lesion with a speculated outline, and here causing the atelectasis of there is a mass here and causing obstructions of the bronchus intermedius, causing collapse of the middle and lower lobe. Bronchoalveolar carcinoma, this is the third common type. It's well differentiated adenocarcinoma. It's appeared as a small peripheral tumor, either as a small peripheral tumor with a 100% survival to the widespread advanced disease, most commonly indolent and often negative on PET. So in this case, they need late follow-up. It may change after till 4 years. We have many types, but these are pictures of two types. We have non-mucinous and mucinous type. Non-mucinous with a good prognosis, and this is has a bad prognosis. Appeared as the solitary, as a pulmonary nodule with air bronchogram or ground glass opacity, and in the mucinous types appears as the chronic consolidation, and this one has a bad prognosis. Other type, we have the small cell cancer. This one is associated with the various paraneoplastic syndrome, strongly associated with smoking, occur in the central bronchi with invasion through the bronchial wall, typically present as a large hilar or perihilar mass, mostly causing superior vena cava involvement and causing obstruction. Rarely is present as the solitary pulmonary nodule. Other types, you have the large cell cancer, which is strongly associated with smoking, poor prognosis, occur as a large peripheral pulmonary mass. Other type, we have the carcinoid. It's appear as the mass, as the endobronchial mass distal to the carina, and may cause obstructive atelectasis, or may appear in 20% as a pulmonary nodule. We have two types, typical and atypical. Typical variant is a low grade, good prognosis. Atypical variants, the more aggressive, arise peripherally and with a worse prognosis. These are the pictures of the carcinoid. There's invasions of the endobronchial in the left main bronchus. Here is appeared as the pulmonary nodule anterior to the pulmonary artery, and this solitary nodule, in this case, it is not differentiated from the other cause of the solitary pulmonary nodule. And here there's causing the atelectasis, segmental atelectasis. We have radiological imaging of lung cancers. It's appear either as a solitary pulmonary nodule or mass. We know that the nodule is less than 3 centimes and mass is more than 3 centimes. Or appear as a segmental or lobar atelectasis. This atelectasis is either due to the bronchial obstruction or obstructive pneumonia, which is due to the bronchial obstructions and parenchymal consolidation caused by the inflammatory cell and lipid-laden macrophage. Or appear as the consolidation, like bronchoalveolar carcinoma. We can differentiate it by, it's just like a pneumonia, but we can differentiate it that it's not responding to treatment and normal YBC count. So here, lung cancer, there is consolidation in the left upper lobe with the air bronchogram surrounded by the ground glass opacity. This is similar to that of the pneumonia. Here also, it's this cancer after the biopsy, and this also, there's opacity here. It's proven to be the squamous cell carcinoma.
So you give treatment,
not responding.
You go forward.
Yes. Other presentation is the hilar mass. It's most common in the squamous cell carcinoma and small cell carcinoma. The hilar mass either due to the central tumor or the nodal metastasis. Tumor may compress and narrow the bronchus, tapered bronchus. If we see the tapered bronchus, and it's specific for carcinoma. Here this is the mass, perihilar, and here. Also, other presentation is the superior sulcus tumor. It regards the T3, and later on I will discuss it. Pancreas tumor is the type of the superior sulcus tumors and affect the sympathetic ganglia, causing Horner syndrome, ipsilateral ptosis, meiosis, and anhydrosis. Here there is opacity in the right apical area. This is the CT, select image of the CT scan, causing there is consolidation with mass invading the wall, adjacent skull, and here also affecting this is the MRI. This affecting the chest wall, and here the CT affecting the rib. Other types, the lymphangitis carcinomatosa, which is the late stage of the disease and of the CA, and it's diffuse lymphatic spread. It's appear as the nodular interlobular septal thickening. Other find here, there is unilateral interlobular septal thickening, nodular, and the other side is normal apart from some pleural effusion here. Other have the pleural effusion either due to lymphatic obstruction or pleural metastasis. Malignant effusion is regarded as the M1A. So not every case in lung carcinoma, if there's pleural effusion, it's carcinoma. So we should do aspiration to confirm. Yes. Pneumothorax is not common. It's occurred in the case of the peripheral tumor that cavitate or invade the pleura. Here is a rare case. This is the mass, and this is the pneumothorax. We have TNM classification. T is a tumor. T1 is the tumor less than 3 cm, surrounded by the lung or visceral pleura. We have subtypes of this, either A or B. The A is less than 2 cm. The B is less than, between 2 to 3. And survival is 77% from the stage 1A. T2 tumor 3 to 7 cm, or local invasions of the visceral pleura, endobronchial lesions more than 2 cm from the carina. It's stage 2. And it's divided into A and B according to the size. Size 3 to 5 is T2A. T2B is 5 to 7. Stage T3 tumor more than 7 cm, or local invasions of the chest wall, diaphragm, pleura, superior sulcus tumor, or endobronchial lesion less than 2 cm from the carina. And if there's less than 2 cm is T3, more than 2 cm is T2. Also, we have separate tumor nodule in the same lobe, also is T3. If we have separate tumor nodule in the different lobe in the ipsilateral lung, and different loop in the ipsilateral, one lung in yes, in different lobes, it's T4. But if the separate tumor nodule in one lobe, so it's T3.
You treat every lobe as a different one.
Yes. Yes.
Lobe
yes. Or a tumor of any size with the invasion of the mediastinal structure, including carina, heart, great vessels, or vertebral bodies. So we see that the 5-year survival rate from the 77% from the T1 is decreasing to the 5-year survival rate to 22% in stage 4. Here, this is the T1, atypical T1 tumors in the left lower lobe, completely surrounded by the pulmonary parenchyma. Only just we have this nodule, this is the T1. In this case, we have a typical T2 tumor with atelectasis, pneumonitis of the left lower lobe up to the hilum due to the involvement of the left main bronchus. Here, this is away, more than 2 cm from the carina. Here, we have this mass. This is the T3 tumor, right upper lobe, with the invasions of the chest wall. This T3. This T4, invasion of the chest wall, mediastinum. Okay. We have lymph node, N0 no lymph node metastasis, N1 ipsilateral hilar. Here, ipsilateral. This, if you imagine that's the mass, ipsilateral lateral hilar or intrapulmonary node, hilar interlobar. Here, hilar interlobar segmental and subsegmental. N2 is ipsilateral mediastinal, here, ipsilateral mediastinal nodes. This includes the upper tracheal, upper paratracheal, prevascular, paratracheal, subaortic, para-aortic, and pre-esophageal, pulmonary ligament nodes. N3, contralateral lymph node, all these, but if it's contralateral or supraclavicular lymph node. So here it's N1 because there is the ipsilateral in the right lower, there is a tumor more than 3 cm in the right lower lobe with the ipsilateral hilar node here, ipsilateral to the mass. Here is contralateral on the with the ipsilateral mediastinal node. Sorry, right side tumor. Yes. Here, 2 patients with the N3 disease on the contralateral side. This is the mass and this is the other lymph node. On the contralateral side, this is N3. Metastasis, we have M0, no metastatic disease. M1A, it's local thoracic metastatic disease. Separate tumor nodule in the contralateral lung, malignant pleural or pericardial effusion. M1B is distal or extrathoracic metastatic disease. We have T and M staging system. We have 4 stages. Stage 1, 2, 3, and 4. Stage 1A up to T1B, there is no lymph node, no metastasis. T2A, no and no metastasis and no lymph node. T2A up to T2A, if there is lymph node 1, if N1, or T2B if no lymph node, there is no metastasis. Stage 2B, T2B if there is lymph node involvement, or T3 if no lymph node, no metastasis also. T3A up to T3 or T4, T3 if N2, or T4 if no or 1, or N1, no distal metastasis. 3B, any T, or T4 if N2, not N3, no distal metastasis. For any T, any N, M1 or M1B.
So any metastasis is stage 4?
Yes. So here is a stage 4 disease, left upper lobe mass with ipsilateral hilar lymphadenopathy. And here up, there is also invasions to the both adrenal. So this metastasis is stage 4. This also stage 4. There is a large mass here, and the contralateral small nodules appear. And this is the stage 4 disease. This stage 3A disease, because we have the mass abutting the pleural surface and more than 3 cm with the lymph node. So it's regarded as stage 3A. Thank you.
Thank you very much. Very informative talk. Any questions? Comments?
And if we have a